Now we are going to start with the reproductive physiology. The reproductive physiology will be discussed under the following subheadings, that is the disorders of sexual development, then male reproductive system and female reproductive system. In that the most important aspect is the disorders of sexual development. Now coming to the disorders of sexual development, basically the sexual disorders are classified, or the sexual development is classified into three different stages. The first one is the chromosomal sex. What is a particular chromosome of the person? So that is chromosomal sex of the person. And it is further divided into XX in case of females and XY in case of males. Now coming to the genotypic sex. What is genotypic sex? Genotypic sex is the sex that is determined by the gonads of the particular person. What is the gonads in case of the males? The gonads is the testis, and what is the gonads in case of the females? It is nothing but the ovaries. And coming to the last one, that is the phenotypic sex. What is phenotypic sex? It is the external appearances of the person. So the third one is the phenotypic sex. So these are the three different aspects through which the sexual development happens, and the characteristics of a male and a female is given with respect to all these three things. Phenotypic sex, in case of a male, it is masculine, that is increased muscle mass and change in voice and everything, masculine features. Whereas in case of the females, it is the breast development and feminine feature development. So these are the three different grades or the three different forms of the sexual differentiation. More than all these things, what sex is more important? With regard to the sexual development of a person, we should give more importance to the psychological sex of the person. It is the psychological sex of the person that should be given importance. Just because somebody's chromosome is XY, it is not that he has to be developed as a male person. If a person wants to be in a feminine character, that should be respected, and the community should not be forcing them. And it is the psychological sex that should be helping the person to develop, because that impacts all the sexual characteristics and psychological behavior of the person. So that is very important. Now coming to the development of this male and female characters, how does it get differentiated in male and female? The most important and the primitive structure that is present during development are the Mullerian duct and Wolffian duct. Mullerian duct is the one which is responsible for the development of female characteristics, whereas the Wolffian duct is the one which is responsible for the male development characteristics. And how does it get differentiated? How does the gonads get differentiated? How does the external features get differentiated? The male is the one which is differentiating from the female. How does it happen? There is a particular gene in this Y chromosome. What is the name of the gene? The gene is called as SRY gene. What is this SRY gene? It is nothing but sex determining region in Y chromosome. Sex determining region in Y chromosome. If this particular Y chromosome has this sex SRY gene, then the characteristics will be developed as a male. If it is absent for a female character, it is like a default. So if it is absent, then obviously female features will be developed. So what does this SRY do? It can act on various different cells in the body, especially the Leydig cells and the Sertoli cells. So Leydig cells it acts on, and it starts to produce the testosterone. So it is starting to produce the testosterone. So this testosterone will help it to develop into a male characteristic feature. Then another one is Sertoli cells. What does this Sertoli cells do in case of a developing embryo? This Sertoli cells, they produce something called as MIS. What is this? Mullerian inhibiting substance, or AMH. What is this? Anti-Mullerian hormone. So this Mullerian inhibiting substance or the anti-Mullerian hormone. So both of it says that it is going to inhibit the Mullerian. What is Mullerian? Mullerian was developing into a female sex type. If it is inhibiting it, then obviously the male characteristic features can be developed. That is why this SRY gene is very important in case of a development of a male. Now coming to the disorders. We will be studying the disorders in chromosomal sexual disorders, then followed by that genotypic and phenotypic will be combined and studied. So first coming to the chromosomal sexual disorders. So the most important chromosomal sexual disorders are two things. One is the 45XXY. What is this syndrome? All of us know this syndrome is Klinefelter syndrome. Klinefelter syndrome. And there is a chromosome disorder which is called 45XO. Here one X is absent, that is called as Turner syndrome. So these are the two most important syndromes we have to know. And if the fetus is not having an X chromosome, then most of the time it is not viable. That is why we don't find any disorder something like this. We have 45XXY and 45XO. These are the two most common important chromosomal sexual disorders. Now coming to this, we will be discussing all the chromosomal sexual disorders under the following four subheadings. First, we will look at what is the chromosomal sex. What is the chromosomal sex? Tell us whether it is a male or a female. And what is the genotypic sex? What will be the genotypes or the gonads? Then phenotypic sex, or the features of it. Then finally the breast development. These are the four important parameters that we are going to consider. So first coming to the chromosomal sex. As it is indicated, XY is there. So the chromosomal sex tells us it is a male. What is the genotype? Here the genotype is testis, but the testis is hyalinized. There is formation of hyaline membrane. There is no proper development of testis. So hyalinized testis will be present. Then what is the phenotypic sex? The phenotypic sex also will be male, but since it is hyalinized testis, the production of testosterone is reduced. So the male but immature, little bit immature and little female type characteristic will be there. Then testosterone is reduced. So what will happen? There is an increase in FSH and increase in LH. What they can do is they can indirectly stimulate the adrenalines and produce DHEAS. What is this DHEAS? That is called dihydroepiandrostenedione. This DHEAS can get converted into estrogen. In the peripheral adipose tissue, this can get converted into estrogen. Now, estrogen is available. It is a female hormone. So, what does it do? It can lead to the development of breast. So, breast development will be there, and it is a male person. So, what is it called as? It is called as gynecomastia. Gynecomastia. So, these are the features will be seen in case of a Klinefelter syndrome. And obviously, since there is a hyalinized testis, the fertility is also reduced. And gynecomastia, usually the treatment option is to do with a surgery. So this is a classical example of a person who is having Klinefelter syndrome. As you can see here, there is presence of gynecomastia and feminine-like features. The gynecomastia will be there, plus feminine-like features will be there. So this is a classical example of an 45XXY, which is a Klinefelter syndrome. Then coming to the next disorder, which is called as Turner syndrome. What was the chromosomal defect there? It is 45X0O. Again, what will be the chromosomal sex? Chromosomal sex X is there, and obviously Y is not there. So the chromosomal sex tells us the person is a female. What is the genotypic sex? Here the genotypic sex is ovary. Again, there is absence of one X chromosome. So the ovary is not developed properly. It will lead on to streak ovaries. And what is the phenotypic sex? It will be again female only. Female phenotype will be there. Since Y is not there, then what will be the breast development? Breast development will be immature. What is the reason for this immaturity? Since ovaries are streaked, they are not properly functioning. So there is a reduction in estrogen levels, the female hormone, so which is leading on to the immature breast development. So this is the features of it. And associated features will be there. In question also, they will obviously give you this picture or the associated features along with this examples. So associated feature, what is associated features? As you can see here, it is cubitus valgus. The hand will be a little deviated. That is called as cubitus valgus. Then other than that, the person will have a webbed neck. As you can see from this diagram, there is webbed neck appearance. So these are the two classical features that is seen in a case of Turner syndrome. What is the other features that can be seen? The other features that can be seen is the patient will have coarctation of aorta. So the aorta is getting coarctation. So what will happen to the BP? The blood pressure level increases, leading on to hypertension. So the patient may present to you with a hypertension also. This is one feature. And another feature, radiological imaging, they show that the person might have a horseshoe-shaped kidney. So this can be the features of the particular person who is having a Turner syndrome. So we are done with our chromosomal sex disorders. Actually, previously this chromosomal sexual disorder, they were represented as pseudo-hermaphrodites. Whenever the features of feminine features are present in a male or male features are present in a female, they call it as pseudo-hermaphrodites. And there is another disorder which is called as ovotesticular disorder. Here there is presence of little bit of ovary also and testicles also. So it is like a mixture of both of it. They were initially called as true hermaphrodites, but this term is completely not used these days. We use only the disorders of sexual diseases. Both the testes and ovary can be present in this particular person. So what will be the features? The features will be dependent upon the dominance of these two structures, whichever is functionality is there. Then depending upon that, the person will have a mixed features. So these are the examples of disorders of sexual development with respect to the chromosomal abnormalities. Now coming to the genotypic and phenotypic sexual disorders. The genotypic and phenotypic sexual disorders depends upon the gonads present and the external features that is manifested. So what could be the two types of disorders is, one is the underandrogenization. There is a reduction in androgen because as such androgens are the one which is determining the formation of the male sexual characters. By default it can go to the female sexual features. Now coming to this underandrogenization and overandrogenization. Overandrogenization, what can happen? The masculine features will be increased. Masculine features will be prominent. They will become very prominent, the muscular features. Then the underandrogenization is more at a problem because the proper androgenization is not happening in that case of a particular male individual. So what it can happen, there is a defect in testis development. It can happen in three levels. First thing is the testis itself is not developed properly. Defect in testis development. Second thing is there is a defect in the production of androgen. So there is a defect in androgen production. And finally, androgen is normal, but they have to go and act on a particular tissue. We have an interesting syndrome there that has to go and act on a particular tissue. If they are defect, then also the problem will be there. Defect in androgen receptors. Androgen receptors. So these are the three major classifications of this disorders. Out of this, we'll start with the testis development disorder. Whenever there is a partial defect, what will happen? There will be a decrease in masculine features. There will be a decrease in masculine features. It is not a very big defect because partially it is present. So there is some defect in the masculine features will be there. Whenever it is completely defective, what will happen? This syndrome is called as Swayer's syndrome. Swayer's syndrome. And if testis is not developed properly, what will happen? The production of MIS, which we saw, that is Mullerian inhibiting substance, is also decreased. So what will happen? The person will show feminine features. The person will show feminine features. So these are the problems and defect of testicular development itself. The syndrome here, it is called as Swayer's syndrome. We should remember, and it is a complete defect in testis development. Partially, it is just a masculine feature defect will be there. So coming to the androgen synthesis defect, this is the most important topic among the entire DSDs. So coming to the androgen discussion, first we have to know the pathway of production of androgens and cortisols. So first starting with the starting point, for all this the precursor or the material which is required to begin with is nothing but the cholesterol. Cholesterol, we might hate it, but it is the predominant substance which is used in many of the hormonal productions. So let's start with the cholesterol. So cholesterol is present. The cholesterol in the presence of a protein called star protein, STAR star protein, what it can form is, it can form pregnenolone. It can form the substance pregnenolone. We'll just see the pathway first, then we'll add on the enzymes. So this is the basic pathway. From pregnenolone, it can get converted into progesterone. From pregnenolone, it is getting converted to progesterone. From the progesterone, it will get converted to 11-deoxyprogesterone. And this 11-deoxyprogesterone is like the base product for both the pathways. What are the pathways? One is for the cortisol production, another one is for the androgen production. So 11-deoxyprogesterone will get converted to 11-deoxycortisol. Then finally this 11-deoxycortisol will get converted into cortisol. This cortisol is very important. This cortisol is very important. I will tell you in some time what is its importance here. So coming to the other side of the pathway, what happens? There is production of testosterone. And testosterone can get converted into a more active form, which is called as dihydroepiandrosterone, which is a most active form of the testosterone. So these are the substances which is produced from this pathway. So what are the enzymes responsible for this pathway? Depending upon the enzyme defect only, we are going to study the disease. So first thing is, this cholesterol will get converted to pregnenolone in the presence of two important substances. What are they? They are nothing but ACTH, adrenocorticotropic hormone. So this is ACTH. Next one is LH, that is the luteinizing hormone. Luteinizing hormone and ACTH are more important for the transformation of these substances. Next comes the pregnenolone to progesterone conversion. This conversion happens in the presence of 3-beta hydroxysteroid dehydrogenase. 3-beta hydroxysteroid dehydrogenase. Then there is one more person who is coming and entering this pathway. Here you have to remember it is 20-beta hydroxylase. 20-beta hydroxylase enzyme. And this 11-deoxycortisol is finally converted into cortisol in the presence of a substance 11-hydroxylase. This is called as 11-hydroxylase. All these enzymes are important because their presentation is going to change depending upon the enzyme deficient. Then coming to the other side, there is one hormone which is involved here, which is called as 70-20 lyase. 70-20 lyase. So we have to remember all the substances: 3-beta hydroxysteroid dehydrogenase, then 20-beta hydroxylase on this side, then 11-hydroxylase, then finally 17-20 lyase. So now let's try to understand what happens. So the end product, I told you, this is the cortisol, which is very, very important. What is the function of this cortisol? This cortisol is the one which is going to inhibit the ACTH. So cortisol is the one which is going to inhibit this ACTH. Feedback inhibition. This is nothing but our feedback inhibition. If this inhibition is not there, let's take an example. If this inhibition is not there, what will happen? There will be a raised amount of ACTH. And ACTH, if it is raised, where it is going to act? It is going to act on the adrenals. So if the cortisol production is not there, what is happening? There is an increase in ACTH. And if there is an increase in ACTH, what is going to happen? This increase in ACTH is finally going to cause adrenal hyperplasia. Adrenal hyperplasia. Why it is causing hyperplasia? Now it is going to stimulate the adrenals to ask it to make it more and more products, but there might be an enzyme deficiency through which it is not produced. If the end product cortisol is not available, it is going to produce an adrenal hyperplasia. So let's start with the first enzyme, that is the 3-beta hydroxysteroid dehydrogenase. It is the starting point. Here itself the enzyme is absent. So what will happen? There will not be production of cortisol. So in this, what will happen? There is decreased cortisol. And what is happening to the level of androgen? The starting pathway itself is defect. So decreased androgens also. Androgens. So there is decreased mineralocorticoids also. Mineralocorticoids also. So why is mineralocorticoid deficient? Because this 11-deoxycortisol has a strong mineralocorticoid action. So that will also be decreased. So all these are decreased. And I told you, whenever the cortisol is decreased, what will happen? It will lead on to a particular disease called as adrenal hyperplasia. It is from the congenital, it is from the birth it is happening. So it is called as congenital adrenal hyperplasia. That is a classical thing, we call it as CAH. This can be asked in MCQs, what all the enzymes. So first, congenital adrenal hyperplasia can happen. Next thing, if it is a female child, we don't need androgens at all. But if it is a male child is having this defect, this enzyme defect. So what can happen? The androgens are not produced. So what will happen to the child? There will be male under androgenization. So if it is a male child, then the problem is more severe. Androgen is also not available. So congenital hyperplasia with male under androgenism will happen in case of 3-beta hydroxysteroid deficiency. Now coming to the second enzyme, that is 20-beta hydroxylase. 20-beta hydroxylase, what will happen? Cortisol is produced or not? The cortisol is not produced. So what can happen? There can be a congenital adrenal hyperplasia. That is true, because cortisol, as and when it is not formed, we are going to have a congenital adrenal hyperplasia. Along with that, what is happening? In a male child, is it a problem? No. Why? Because now 11-deoxyprogesterone will be available in more, because if the pathway is cut here, what is going to happen? The pre-product is going to increase. So 11-deoxyprogesterone will be more. So where is the pathway diverted? The pathway will be diverted to this region, and this enzyme 17-20 lyase will be completely fine in this person, and there will be lots of production of androgen. So in a male child, it is not a problem, because there is going to be more androgenization. That's it. More masculine features will be developed. There is a little problem, but not severe. But what happens in a female child? In a female child, it will go for an androgenization. Why? Now this entire cortisol pathway is diverted to the androgen pathway. We have a cortisol pathway and androgen pathway. If this pathway is gone, what will happen? It will be diverted to the next pathway, that is the androgen pathway. So female, this is very important, female androgenization can happen. Androgenization can happen. I hope it's clear. Now coming to the 11 hydroxylase enzyme. So in 11 hydroxylase enzyme, what is happening? Same thing will happen. Cortisol is not produced. Will CAH be there or not? Yes, CAH will be there. Congenital adrenal hyperplasia will be there. So next step is, what is going to happen? We saw that the 11 deoxycortisol is a mineralocorticoid in action. So if 11 deoxycortisol is produced more, so if the pathway is cut here, what is going to happen? 11 deoxycortisol is going to stay there for a longer time. And what is the action of it? Its action is a mineralocorticoid action. So if it is a mineralocorticoid action, what it is going to do? It is going to take in more and more sodium reabsorption, and finally the person will have hypertension. Hypertension. So this is a differentiating feature from here. And will this person have female androgenization? Obviously yes, because the pathway is cut here. 11 deoxy will be accumulated, but other than that, even more of production of androgens can be there. So female androgenization also can be there. We will summarize all of them in the next slide, but now we should understand what are the concepts. Now next, coming to the 1720 lyase, what is happening? Here the pathway is cut, so the androgens are not produced. But what will happen to the cortisol? Now cortisol will be obviously produced. So will there be congenital adrenal hyperplasia? Congenital adrenal hyperplasia will not be there in this person. So what is the only problem here? Here the only problem is androgens are not produced. So what is it will not affect a female child, but in a male child, what will happen? There will be male under androgenization. Male under androgenization. So this is very, very important, this male under androgenization, because nothing else will happen in this person. So this is just a recap of everything. So first thing is, if this enzyme is cut, what will happen? Congenital adrenal hyperplasia along with male under androgenization. So these two enzymes, both of it will cause congenital androgenization, but congenital adrenal hyperplasia plus female androgenization. But 11 hydroxylase is very specific for causing hypertension also. Then 1720 lyase, if you see this pathway, it is very, very essential for only the androgens. So congenital adrenal hyperplasia itself won't be there, only the male under androgenization will be there. So now let's summarize all that we have learned till now. So when cortisol is deficient, what is going to happen? It is going to increase the ACTH, and finally it will cause adrenal hyperplasia. Now coming to congenital adrenal hyperplasia, out of this, all this enzyme, which is the most common enzyme deficiency, the most common enzyme deficiency is 21 beta hydroxylase. 21 beta hydroxylase. So what are the problems we are facing? The problems we are facing is mineralocorticoids can be deficient, glucocorticoids can be deficient, and finally there can be an ambiguous genitalia also, because in a female child, what will happen? Over androgenization can happen. So that will cause an ambiguous genitalia kind of features. Coming to congenital adrenal hyperplasia, now we will study the differentiating features. So first, starting with D3 beta hydroxysteroid dehydrogenase, the starting pathway itself. So both mineralocorticoid and glucocorticoid will be down, and there will be male under androgenization. Next, coming to the one pathway, that is the cortisol pathways defect, there can be a 11 beta hydroxylase deficiency where both mineralocorticoid and glucocorticoid is down, and female will have ambiguous genitalia because female androgenization will happen, because now this pathway is shut down, everything will be turned into an androgen. Now coming to the last one, that is the 11 beta hydroxylase in congenital adrenal hyperplasia. Here glucocorticoid will be deficient, but deoxycortisol will be increased. And I told you it has a mineralocorticoid action which will cause sodium reabsorption and finally causing the hypertension in that particular patient. So these are the differentiating features. And finally, why we have separated it separately? Because this disease will not have the congenital adrenal hyperplasia at all. That is the enzyme deficiency 1720 lyase will not have adrenal hyperplasia at all. There only the androgens are defective, so it is not a problem in case of female child, but in a male child there is under androgenization and there is no congenital adrenal hyperplasia. So this slide is very, very important. We have to remember every aspect of it. They can ask you any of the enzyme defect. Just remember the pathways and write and fit the answers accordingly. Now coming to the androgen receptor defect. So what is happening whenever there is an androgen receptor defect? As we saw, there can be an androgen first thing is we started with our chromosomal defect, then we saw the genotypic defect. In that genotypic defect, we have discussed with the androgen testis development and androgen synthesis. Now, in this androgen receptor defect, the androgens are available. So, what happens here is androgens will be available. That is, the testosterone will be available. But it is not going to act on the testosterone receptors. So, now we are going to understand what happens in this kind of condition. So, there can be a partial defect also, which is not a major problem because at least half of it is functional. In a complete defect, previously this syndrome was called as testicular feminizing syndrome. Previously this syndrome was called as testicular feminizing syndrome. But right now that name is not used. It is otherwise called as, we will understand this testicular feminizing syndrome also. Right now we will another disease, another name for this, the current name used is androgen insensitivity syndrome. So let's try to understand what happens here. Here the androgen is produced. So basically the person is a male. So the chromosome 6 in this person is usually a male type of 6. So it's usually a 46XY only. But what happens here is the genotypic 6 also will be the testis only. So testis is present, but it is usually present in the abdominal side. So what happens if the testis is not functional? Testis is producing androgens. Even for testicular descent, there should be the development of the, there should be the production of testosterone, which is bringing it back to the scrotal levels. But since it is not available, the testis usually stays in the abdominal. And this abdominal testis is very, very dangerous. Now this person is having testis. The phenotypic sex expected is a male, but androgens are not acting. So what will happen? There will be a feminine feature development. And I told you this testis is able to produce the testosterone, but it is not acting in the required way because androgen receptors are not there. So what will happen to this testosterone? In the periphery, this testosterone will get converted to estrogens. So lots and lots of estrogen will be available for this person. That's why it is called testicular feminizing syndrome. Testis is indirectly producing the lots of estrogen through the testosterone conversion. So this estrogen, now what will happen? It will lead to lot of feminine features, and since it is very essential for breast development, the breast development is also very good in this patient. So this patient, from the external features, they will look exactly like a female. They might even look like models also because of the extensive availability of the estrogens. But the entire internal sex is male and the person is having testis, but it is usually located in the abdomen. So it goes unnoticed, and usually the brought up of this person is like a female. So how do they come to the diagnosis? First thing they come to the diagnosis, they will present with amenorrhea. They will not reach menarche at all. Amenorrhea will be there, like menarche is not attained. Then finally what will happen? There will be a blind uterine pouch. Why uterine pouches are being developed? Because testosterone is the one which has to inhibit all the male, which has to inhibit all the female characters. That is not available. Amenorrhea, blind uterine pouch will be there. Then what can happen? There is an excessive breast development, and external examination itself can tell us the clue. There will be absence of axillary and pubic hair. Axillary and pubic hair. Pubic hair will be absent. So what is the reason for this? Even in case of females, the axillary and pubic hair are due to which hormone? That is, even in females, it is due to testosterone. But in this person, the person is not having testosterone at all. So what will happen? They will have a axillary and pubic hair absence will be there. Absence of axillary and pubic hair. And this could be one of the clues. From their childhood till they attain the age of pubertal ages, there will be absence of hair, and while doing an examination this can give us a clue. And the blind uterine pouch will be there, and when an USG abdomen is done, the testis is usually in the abdominal side. So what can be the treatment for this person? So usually the psychological sex preferred for these kinds of persons are the female, because they have been brought up as female, so that should be left to it. Just because the person is having an XY chromosome, it doesn't mean that the psychological sex should be a male. So they can be brought up as a female, and if required, they can adopt babies. So that should be the guideline for this. And what is the best treatment for this abdominal testis? The abdominal testis should not be left as such. Why? Because they are at an increased body temperature. Whenever the testes are under increased body temperature, what can develop? they can develop carcinomas. So that is the most biggest disadvantage in this people. So that's why we constantly advise them, always we have to check an USG abdomen and look for the testicular position. And if it is there in the abdomen, then we have to go for gonadectomy. Because as such, this person does not need testosterone at all. It can be, if needed, some amount of can be other hormonal therapies can be supplement. So gonadectomy is the treatment for it. So this is all about the different types of disorders of sexual development.